Good morning, good afternoon. Thank you very much for this very kind invitation to come and speak to you today about acute on chronic liver failure. Here are my disclosures, none of which are really relevant to what I've got to tell you, but I'm passionate about finding new treatments for this condition, and a lot of my conflicts here are related to new therapies that we are hoping to develop in the future. So what I'm going to try and cover today with you is to try and indicate to you what is acute on chronic liver failure, and to impress upon you that the way we now assess patients with acute on chronic liver failure has been very well validated. We'll talk a little bit about the prognostic and the pathophysiologic basis of the disease as a basis of developing new therapies, but of course focus on the topic of general management. We can talk about potential new therapeutic approaches, and I'm going to finish with talking about how liver transplantation is now becoming an important treatment for these patients. So put the story into context, and I think it's really important for you to understand this because it goes to the heart of the issues we're dealing with in terms of classification of this disease. So here is David, who is a 52-year-old man who drinks excessive amounts of alcohol. He came to see me with alcoholic cirrhosis, but he was very well compensated. He was well at the time. He went away, continued to drink a little bit of alcohol, and he presented to the hospital about 4.5 years later with an episode of acute decompensation. And his acute decompensation on this instance was related to a pneumonic illness. He had high fever, leukocytosis, high CRP, ascites, and jaundice. And he came into the hospital with that acute decompensation, and within a matter of 4 or 5 days, developed this severe syndrome where he was progressively more encephalopathic. His bilirubin was high, INR was very high, and we diagnosed him with acute on chronic liver failure at that particular time. When you transition from this particular state of acute decompensation to development of 3 organ failures, and that's what I'm going to show you next slides. But before I go there, I think it's really important to understand where this sits in terms of the 3 major classifications that you might have heard of. I'm focusing, and for the rest of my talk, on the best validated of these, which is the EASL-CLIF Criteria, which essentially thinks about organ failure at the basis of diagnosis of ACLF. The APASL criteria is based around the diagnosis being on jaundice with ascites, with or without hepatic encephalopathy, as the diagnostic criteria, but it does not include patients with previously decompensated cirrhosis, or those with gastrointestinal bleeding, or with bacterial infection. And if you use those APASL criteria, you would have thought that when he goes to the ICU, you would not have ACLF, and that's really important to understand. The NACL criteria was developed really in patients with infection, which really APASL would not even recognize. That is specified that 2 organs, circulation, kidneys, and brain, and lung, the 4 organs. So if you see here, they left out liver, which is bilirubin and coagulation in the diagnostic criteria. So if you use the NACL criteria, you would have thought that our patient does not have ACLF. So fundamental differences between these 3 are really listed out there. So in EASL-CLIF criteria is very inclusive. APASL excludes patients, and so does NACL. The diagnostic criteria for ACLF is really encompassed within what we call the CLIF organ failure scoring system. And fundamentally, it's based around what we already know in patients with cirrhosis, that when there is very high bilirubin, or the kidneys start to fail, or the patients become very encephalopathic or very coagulopathic, develop circulatory failure or respiratory failure, they have increased risk of dying. And this has been shown in many studies. So there's nothing really new about it, apart from the fact that, as you can see here, if I divide the patients up into those without any organ failures here, the risk of 28-day mortality is very low. But if there are 1 or more organ failures, this increases progressively from 18% up to nearly 90% with 3 to 6 organ failure. So And this is the failure of the organ criteria is defined here. So failure of the organs, number of organs are associated with increasing the risk of death. But it's also important to understand that this syndrome is not fixed. It is dynamic. And this gives you the opportunity to interact with your patient in order to determine what the chances of reversibility of this disease condition is. And that's really defined in this diagram here. What it shows is that wherever a patient starts, they may have 1 organ, 2 or 3 organ failure. If they resolve their ACLF, absence of organ failures, their mortality risk is like that of a patient with no organ failures. If, however, they remain in the state that they're in, for example, if ACLF3 stays as ACLF3, then the risk of death remains extremely high. And the chances that they will reverse their syndrome is dependent upon the severity of ACLF at presentation. So final score is measured. The last assessment is day 5 to 7, and these are the scores at presentation. So it is really, really important that we get these patients early and intervene early in order to have the best effect. And the second thing about this slide is it tells you a little bit about reversibility and lack of regeneration, particularly in those with ACLF3. And this will come to light a little bit more as we move forward. So the diagnostic criteria for ACLF was really based around the canonic study. And again, this slide is only to show you that bacterial infection is a very important precipitating event for the occurrence of ACLF. And this is what this slide is looking at, precipitating illnesses leading to ACLF, which a PASL does not recognize. And the second one here is gastrointestinal bleeding as a precipitating event. And although it's not necessarily overrepresented, there's certainly a significant proportion of patients who present with GI bleed as a basis of development of ACLF. And that is what is trying to show here, that it is very clear that both GI bleeding and bacterial infection precipitate the occurrence of ACLF and are not necessarily a consequence as has been interpreted in other places. I just want to highlight a little bit more gastrointestinal bleeding and ACLF. And this is some recent paper from our own group where we looked at what determines the mortality of patients with cirrhosis in whom we cannot control variceal bleeding. As you can see here, it is really dramatic. In patients who have got the same severity of bleeding, the risk of death is related to the severity of ACLF. So here are patients with uncontrolled variceal bleeding and no ACLF compared with the patients here who've got ACLF3. So the severity of organ dysfunction is an independent predictor of the risk of death of patients with variceal bleeding. And therefore, these patients should be included in the diagnostic criteria of ACLF, which a PASL fails to do. This slide here is really just to indicate, I just wanted to focus here, which is the most important part of the story. In the PASL criteria, what we do is to exclude patients with previous decompensation as having any chance of developing ACLF. So they're excluded from the diagnosis of ACLF. But of course, you can see here that there is really no difference in those with previous decompensation and no previous decompensation. Nearly 30% of our patients had no previous decompensation, but 70% had a previous decompensating illness. And again, as you can see here, there's no difference in the severity of ACLF, and therefore, to exclude patients with previous decompensation seems like an oversight, and we need to correct that as we move forward. Of course, we as academics and clinicians live and die by validation. So if there's a criteria for diagnosis and prognosis, it needs to be validated around the world. And that's what I show here in this slide. We published this paper not so long ago, but as you can see here in the different colors are data coming from different parts of the world. So it's not a European disease. We have data here from Europe, that was the canonic and the predict studies, Asia, mainly from China and Korea. USA is large numbers of patients because there are large databases that function, and Latin America. So around the world, the findings of the EASL-CLIF criteria have been validated. And just to show you, different colors are represented here. What it shows is the prevalence around the world is very similar. 30% patients at presentation will have ACLF. Another 10% will develop it during hospitalization. The mortality rates at 28 days are very similar, 30 to 40%. At 90 days, 50 to 50 odd percent. And again, across the board. But what is really remarkable is that if you do not fulfill criteria for ACLF, then the mortality rates are dramatically low. So it separates out one from the other. And it is really important to understand that we should stop worrying about a PASL or NACLF or EASL-CLIF. You go with the data that has been validated across the world. And this is what I'm trying to show here. So EASL-CLIF criteria has been validated worldwide. You know, whenever you have a syndrome which is newly defined, it's got a clinical characteristics, it's got a prognostic characteristic. The question is whether it has got any unique pathophysiologic phenomena. And that is what we found here. And this is really important because it goes to the heart of what we do for these patients now and in the future. And I'll just illustrate this to you just to show that the central underlying story, which has never been understood and never been recorded carefully, is what joins all these multiple organ dysfunction. And it is the severity of systemic inflammation. So patients may have hepatic encephalopathy or renal dysfunction or advanced liver injury or sarcopenia or immune dysfunction. What lies at the center of it is systemic inflammation. And that's what you show here, which is worse in patients with decompensated cirrhosis, acutely decompensated non-ACLF cirrhosis, compared with those with compensated cirrhosis. And in ACLF patients, it gets progressively worse. So as you can see here, white cell count, CRP, simple measurements were very dramatic differences. TNF-alpha, IL-8, whatever cytokine is your pet cytokine you want to choose. Systemic inflammation is at the center of this story. Why it's important is really illustrated on this slide. But here is systemic inflammation. Okay? And so what we and others over the last 10 years have been trying to do is to try and understand why had these patients got systemic inflammation. Because if we understand why they have it, then they may become targets of therapy. And that is what new treatments in ACLF are based upon. So the idea here is that here is a patient with cirrhosis who's got pneumonia or acute alcoholic hepatitis. He has all these things going on here. They've got accumulation of pathogen-associated molecular patterns such as LPS. They've got damage-associated molecular patterns, which are products of cell death. They have albumin dysfunction, they're hyperammonemic, they've got metabolic dysfunction. What happens in the organs is they upregulate the inflammasome and the toll-like receptor pathways, because it means that when there is a second hit, like in our patient who got pneumonia, all these systems are activated, leading to this systemic inflammation, which results in organ perfusion problems, metabolic failure, leading to organ pathology and simultaneous or progressive multiple organ dysfunction and death. So therefore, what this gives you is a framework to develop novel therapies. And so you can treat the underlying liver disease, you can target cell death, you can target albumin dysfunction, you can treat hyperammonemia, and the new drugs in development for that. For the inflammasome and the TLR4 side, you can use a TLR4 antagonist. You can use GCSF, which of course has not been shown to be useful, but clinical trials combining GCSF with TAC242 underway, IL-22, plasma exchange, and new liver dialysis machines being developed, and liver transplantation, which I'll talk to you a little bit more about in the next slides. So many, many new therapies on the way. So the management of ACLF really relies on these 3 or 4 elements. It's solid intensive care. There's really no liver support device that is useful, so I'm not going to talk about it, and liver transplantation. I'm going to talk a little bit about the ability of ongoing care, and that is really important to understand. So I'm not going to spend a lot of time talking about the intensive care management, except to say that your team and your unit and your hospital needs to agree a path that you're going to follow for the management of these patients. You need to define the condition first, and you need to agree as to what it is that you're going to follow. And if you took my advice, you'd follow the EASL-CLIF criteria for the reasons that I've laid out and what I'm going to say as we move forward. What about organ failures? How are you going to support the organ failures? And you need to set up your ICU such that you have different organ support systems available to you. You need to generate new protocols that allows you to manage bleeding quickly, infection quickly, what are you going to do with encephalopathy, how are you going to ventilate your patients, and so on. These patients need to be monitored because that's the only way that you'll understand what's going on with them. So what are you going to use for monitoring the brain, the kidneys, the liver, etc.? And this is a typical intensive care based program. There are many different things out there in terms of mechanical ventilation, which you need to decide what kind of renal replacement you're going to use. Do you have plasma exchange, which of course is not the standard of care, but may be useful in certain patients. So it's doing stuff correctly all the time if you want to have reasonably good output and good effect from management of your patient. You know, one of the most emotive and the most difficult discussions that you have is that you've got a patient with ACLF 3 or 4 that's in the ICU. You've been supporting them for 3, 4, 5, 6 days. Transplantation, for whatever reason, is not an option in this particular patient. What can you do? It is extremely expensive, but also very distressing for everybody around. So the question are there criteria that you can use that allow you to stop the intensive care support? And so we think the CLIF ACLF score, which is a combination of age, white cell count, and the CLIF organ failure score, you can use as a basis to start the discussions with the family that we can start to think about stopping ongoing intensive care treatment. And as you can see, if the score was above 100, the risk of specificity is nearly 100%. Whereas the score is greater than 65, the specificity is about 89%. So if the patient reaches a CLIF ACLF score, which is a score between 0 and 100 of 65 at day 5 to 7 of organ support, it is worthwhile initiating those conversations with the family to see whether you can set some stopping rules or non-escalation routes, which will allow for the patient the relief in a sort of a strange negative way, but also a futility of ongoing ICU care. But of course, this is very difficult, and these scores need to be validated in your country, in your clinical practice, as you mentioned. Finally, and I think this is really important, because transplantation saves the lives of ACLF patients. But of course, in countries such as ours in the UK, and I'm sure in countries where there are cadaver organs available, even in living donor transplantation, there's always a question of equity versus efficiency. You don't want to transplant somebody who's so sick that they have a very high risk of dying. And conversely, you don't want to let a patient that can benefit from a liver transplant die without a transplant. So there is this dilemma, the yin-yang, that goes on all the time in these discussions. But I'll make a few important points. The first is, in a country like ours, in Europe and the US, where organ allocation, which is mainly cadaveric, is based around the MELD score, the question is whether it's appropriate or not. And this brings us back to the heart of the problem. Remember, the CLIF organ failure score, which defines ACLF, scores 6 organ systems. MELD score only includes elements from bilirubin, creatinine, and kidney. Bilirubin, creatinine, and INR. But does not take into account brain failure, circulatory failure, or respiratory failure. So it's not surprising to see that if you look at mortality on the waiting list for a transplant, you look at patients with, and you look at patients with MELD of less than 25, if they've got ACLF 2 or 3, the risk is extremely high, which means that MELD score underestimates the risk of death of patients with ACLF. And this is really important to understand. But of course, the bigger question, of course, is that if I took a patient with ACLF3, multiple organ failure, then what kind of results do I expect post-transplantation? And that's what's shown here. The blue line here are patients with no ACLF, that's ACLF 1 and 2, and that's ACLF 3. And as you can see, even in these very sick patients with chances of dying of over 70%, the risk of the chances of 1 year survival is over 80%. So therefore, very clear evidence in selected patients of transplant benefit. And of course, you need to take out patients who are so sick that they're unlikely to benefit from liver transplantation. How is this being adopted in clinical practice? So one of the low ACLF transplanting countries in Europe are Spain and the UK, who have started to make changes. In the UK, there's an implementation of a new strategy to transplant patients with ACLF 2 and 3, and they now get priority. So the median time for these patients to get an organ now is 2 days, which is pretty remarkable, and we'll see how this program continues as we move forward. In Spain, there's now a new recommendation that these patients should be prioritized for liver transplantation. But of course, there are many questions to answer, and that is going to be addressed in this study, which is a global study, which is called the CHANCE study. And if any of your centers want to participate in this, please write to me, and we can see if we can include you in the study. So the CHANCE study is a global study, all the way from the West Coast in the United States, all the way to Japan and Australia, with many countries in the middle. So if you're interested, please let us know. So therefore, to conclude, Mr. Chairman, I think it's fair to say that the EASL-CLIF definitions and models have been very widely validated and is probably appropriate for patient stratification. Previous decompensation and infection as precipitating important components of AD and ACLF. So if you rule them out, you will miss patients with likelihood of dying. Systemic inflammation underlies the pathophysiologic mechanisms and is the basis of potential new therapies, and there are a multitude of new trials which are now undergoing. Liver transplantation saves lives of patients, and the current organ allocation policies are inadequate, and EASL-CLIF models are now being trialed as we move forward. So therefore, we believe that this is a new dawn for patients with ACLF as we move forward. I just want to thank the many fellows who have worked with me over the years and the people that provide us the funding for my research. So with that, thank you very much for this very kind invitation, and I'm happy to take any questions you might have. Thank you.